So I guess to echo some of the comments we had in the previous session, we're certainly not there for delivering reliably curative options in adults with AML. And we have to do much to improve outcomes by driving trial recruitment. So I think one of the areas I just wanted to talk about briefly was the importance of thinking about, first of all, how we view uh, transplant as almost a kind of central modality for many adults, particularly older fit adults with AML, in terms of delivering cure, but also how we think about integrating transplant with induction chemotherapy. The reality is that we have previously kind of viewed sort of Manichaean philosophy, sort of Near Eastern philosophy of black or white. It's either AML docs talking about chemotherapy options, and then they kind of get sent off to some transplant center in a black hole, or is transplanters not listening to the challenges around getting people into remission? And I think increasingly we're seeing these two as part of a holistic strategy. So the reason I think it's important, this is the HOVON data set that showed bottom panel the reduction in relapse in patients with AML in CR1 who proceeded to transplant compared with patients who just got further intensive chemo. The hazard ratio for relapse is 0.35, and it's remarkable 70% reduction in relapse risk. So the question, I think, is who should proceed to transplant, and how do we actually make transplant outcomes better? So this is data that's familiar to everybody really in terms of which patients should we choose in terms of recommending a transplant in CR1. And we know the calculation in a fit patient with a good donor is in a relapse risk predicted with chemo on 40 or 45% because of that reduction in relapse risk from the GVL effect. Patients with a relapse risk higher than that an acceptable tier are likely to benefit. I just want to put in the caveat here, which is, of course, if we get better salvage regimens, we may actually be able to defer quite a lot of transplants for CR2, and Courtney Donardo's data about Ven-based combinations with intensive chemo is intriguing in that setting. And second, to speak to Lars's point, increasing molecular stratification about which patients are going to do well with chemo. But, I think over the age of 50, that's really a minority of patients, and most people do need to go to transplant. So if we can agree pretty much on who should go to transplant, the question is, how do you make the transplant better? And that is a dialogue, I think, between the people delivering induction chemotherapy and the people delivering the transplant. And I think that's increasingly happening now with understanding more that what you do in terms of induction or consolidation can have powerful impact on transplant outcome. Firstly, by potentially reducing transplant-related mortality. I mean, Jeffrey Lancet's paper with CPX showed that the benefit was primarily in people who went to transplant, whether it's because they had better MRD pre-transplant or because there was less transplant toxicity, but we don't know. And I think some of the triplets that Zen Narvel's pioneered and Nick Short in FIT3 mutated disease, those are really interesting because it is plausible that actually by changing up the induction strategy, you either result in patients who are fitter and can actually go through transplant with less complications and less mortality, or you may actually improve the MRD status. And finally, in the setting of thinking about transplant, I think what we do after transplant is really important, and the data using post-transplant Psi as strategy to reduce the risk of GVHD, I think could be a real game changer, particularly in older patients having a RIC allograft, where we know that any steroid exposure for GVHD is incredibly poorly tolerated. But the bit that I was asked to comment on about was conditioning regimens. And, I suppose this is an area where we kind of have a limited data set. The first question is, should a patient have a MAC or a RIC? And we all know and are familiar with the US-CTN 901 study. That was a nice randomization of myeloablative versus RIC. And what that showed was improved disease-free survival if you had a MAC, and that translated into improved overall survival. There were challenges with that study, and I think this is quite interesting that you do randomized studies, and sometimes you get answers that don't quite make sense. I'm not sure that the recommendation to do a MAC where you can in patients who are fit is particularly surprising. It makes good sense. But what was remarkable about this study, bottom left, is the relapse risk with the myeloablative arm was so low, it was 20%. With the RIC arm, it was 50%. That's just not what we saw in previous trials. And so the bearing that has on how we interpret these data is important, I think. And then, of course, there's the data all of us are familiar with, Chris Hurigan's data, showing that if you were pre-transplant MRD positive using this exploratory NGS strategy, and you had a RIC, your relapse risk was really high. So I think this data is quite easy, even if you can question aspects of it, is if you're fit enough, certainly if you've got pre-transplant MRD, why wouldn't you want to use a myeloablative regimen? And so I think that's important when we're assessing patients at diagnosis, that we should be thinking about trying to keep them as fit as possible so that they can go to a MAC if possible, if necessary. And then the other bit of data, randomized data that we generated in the UK was, if you have to have a RIC, does it matter how you do a RIC? So we use this German sequential arm, which uses 3 days of view. It's really quite a tough regimen for older patients. And what we showed was actually no difference. There was no evidence that intensifying the regimen, keeping people in hospital for another week, made any difference, even if you were pre-transplant MRD positive. And so I guess my observation would be that as we take newly diagnosed patients, we have to be thinking, are they going to be eligible for a transplant? One. Second is, how can I keep them fit enough to go to a MAC? Certainly, people under 55, if possible, we'd like to be taking to a MAC if they've got pre-transplant MRD positivity. And then finally, I think remembering that some patients who don't seem fit when they present after a couple of courses and they go into remission, we see this quite commonly with Ven/Aza, can become fit for a transplant. And so what's needed, I think, to echo what Gail said at the start, we do need randomized studies, not just of induction chemotherapy regimens and triplets, but we do need to think about how we deliver the transplant itself. And so this is a randomized study we just closed out through the UK Impact Transplant Trials Network. This is 290 patients randomized to look at thiotepa added to a myeloablative combo of FB4 or a RIC combo. And the study is now closed, and we will hopefully have that data in 18 months. And then finally, I think the other question intellectually is, does it really matter whether you have a MAC or a RIC? Is it not likely that the most potent anti-leukemic effect is exerted by the GVL effect, and our job is really to maximize that post-transplant? And in fact, the randomized studies should be thinking not just about maintenance, but other strategies by which you could augment the GVL effect. So I guess in conclusion, I'm keen and grateful that we're talking about transplant, but I see it as an integrated proposition with upfront chemo. And I think it's important that we're really imaginative about looking about what we do upfront with patients and how that impacts MRD status and transplant outcome. And we do need to just keep doing some randomized studies. So those were my observations.
I think the objective is to get some reaction to all of that. And I think that Charlie, you can actually tap people and call on people as you like, but I find it irresistible to not mention, because the Hub actually did a good job in putting I think I just saw it on the website, the Sorora paper, which came out in, I'm just pulling it up, I can't remember if it was Blood or Blood Advances, but this is not a randomized trial, but just having a look at 8-year stem cell transplant observations in older AML patients and seeing what happened. And there's a lot to unpack in this paper, and I haven't studied it thoroughly. I think Selina is on the paper. You may have some comments right away, but it was certainly not a resoundingly fantastically optimistic assessment. I think it was rather measured. And basically the conclusion was we're selecting patients for transplant based on a lot of things, how well they are, how good their social supports are. We're selecting really good patients, and yet a lot of them turn to dust and have major quality of life issues and so forth coming out on the other side, even though survival is a bit better. So I read it as kind of a cautionary tale that we better do these randomized studies, because it wasn't completely obvious that transplant was so great for these patients. But I didn't study it. There's an awful lot of data here. And I thought maybe if Selina or if anybody else looked at this paper already or had any reaction other than to agreeing that randomized trials are a good thing, which I think we all would want to do.
So I think there's no question that when a transplant works and the patient survives it, it is their best chance of long-term disease-free survival for the majority of patients that we deal with. The problem is figuring out who those patients should be and helping the patients figure out whether or not a transplant is right for them. You know, I often say to my patients, if you want to be available in 6 months, don't get a transplant. But if you want a chance to be here in 15 years, transplant may be the only way to get there, but you may not be here in 6 months. So, you know, that's kind of the challenge of it. So I agree with you, Gail, that we don't know how to optimize transplant to make sure it's both safe and effective. And that's really the challenge of it, right? And so the question, and can anything we do in terms of, because that's the discussion we're having right now in terms of conditioning regimen, help that? Or, as you just brought up, is it if we don't treat them as much initially, will they be in better shape to get to transplant if we give them less aggressive initial therapy and more likely to tolerate a transplant? I don't think we know the answers to any of those questions. And as you mentioned, the Sorora paper is really a retrospective analysis, doesn't answer that either, and helps us say, again, we don't really understand all the factors. At the time that it does, as it was done, we didn't have a lot of AZA-VEN patients really going into that analysis. And so we didn't really have the current patient population. And I think, it brings up the question of we don't know the answers and we still really need to try and answer them. And the best way to do so is in clinical trials.
One of the things that struck me in the paper, again, and I'm caveating my remarks because this paper needs to be studied more than what I have done. But one of the things that struck me was the use of the C word, so the cure word, and they were trying to figure out in the paper the discussions of cure. And I guess that, you know, not to be don't want to have age cutoffs for anything in the world. I'm opposed to that. But if you are talking about patients over 65 or 70 or 75, certainly my New York patients will be under the impression that if they are going to a stem cell transplant, they really are going in thinking that that is the chance of cure and that 15 years that Selina just mentioned is on the table. And it doesn't actually matter if they're 75 going in. 15 years is supposed to be on the table. And what I do wonder is looking at any of the data, including, you know, all 27 of the patients who've been transplanted after AZA-VEN or whatever our, you know, handfuls are, that and Charlie has to, and I'm not in any way anti-transplant. I just wonder though whether it's the misapplication of the word cure that is the problem here, because patients really are thinking that I'm strong, I'm good, I can walk on hot coals for a few months, but then I'm done, then I'm cured. And I'm just not sure that if you really unpack that word for them, if they are realizing the vanishingly small numbers of patients, again, I'm talking post-65, post-70, forget 15-year survival, which is like 2 patients there, but even the 5-year survival that are what exactly are we being unfair in using the word cure? And that's sort of a philosophical question that I put out there, since it kind of came up in the paper that the patients did think they were going to be cured.
So, you know, that's been done elsewhere where they've shown 2 things. They've asked physicians and patients how likely they think they are to be cured, and both overestimate. But despite what the doctors tell the patients multiply it by 3 or 4.
So, and to dovetail, Charlie just said we need randomized trials. This paper says we need randomized trial. It caveats itself every second line saying this is observational, this is a look, it's not randomized. Are we ever going to do this randomized trial? Realistically, is that going to be randomizable? I mean, we have colleagues in Europe are much better at this than we are. So Gert or Lars or people from countries that actually do these trials successfully, unlike us in the United States where we really don't. Can you randomize, do you think, to answer this question successfully?
Well, I think that the AML patients are so diverse, and AML is so diverse also, that is difficult that we will have the best solution from randomized clinical trials, because in theory, this would be great to do them. But for example, it's very different a patients with an ELN intermediate category, which is MRD before transplant, and is in a very good shape. And what you can expect from transplant is very different from patients with TP53 mutation, who is older, has MRD positivity, and then you decide to do a reduced intensity transplant. Even in this last situation, I question myself whether transplant has any role. In the clinical grounds we have, always it becomes the comment that this patient is incurable. So I think it's very difficult that we will have prospective randomized trials that will be able to answer these questions. And we will have to focus maybe on trials, non-randomized trials with very good biomarkers, including MRD, to decide what to do with these patients. And I think that the main issue is not only to decide when to transplant. Also, this is a matter of debate, because maybe there are patients in which you should proceed to transplant very, very early, even after not achieving the CR, but what to do after transplant. And in this regard, we are far from being successful, because we have tried maintenance with targeted therapy, we have tried hypomethylating agents, and I don't see so far a good option for these patients. So I think that every patient and every situation is different, and it's hard to get an answer from a randomized clinical trial, including a large number of patients with different characteristics.
So I think so we all want it, but we can't have it. So I would like to hear, though, from other parts of the world, can somebody randomize? And actually, I'll make it more difficult, because can you randomize, and also can you tell me what the control arm is? Because there too, with respect to what are they getting? Are they getting maintenance? Are they getting nothing? Are they getting ongoing cycles of aza-ven? If we're taking an aza-ven group to transplant or not to transplant, then the post-remission therapy that they would be getting, I'd like to hear, because I want somebody to do this randomized trial. I don't think I can do it. MD Anderson can't. I don't think you guys can randomize. Naval can jump on if he's still on. That can somebody who can actually randomize these patients tell us how you're going to do it so that we can be supportive?
There have been some biologic randomization trials, right? Didn't BMT-CTN do one where, depending on what your donor, if you didn't have a donor, then you got randomized, either continue looking for a donor or stay on aza, something like that. I forget what I don't remember if it was MDS or AML.
Yeah, that was in MDS.
Yeah,
I was going to say, I was taking a guess that that's maybe they extended
MDS.
it. Now that MDS and AML are the same thing, maybe that can be the same group. But
So
Lars or Gunnar or other parts of the world.
The alternative approach, Gail, before others comment, is to actually start the randomization to ask a different question. Does it matter what induction regimen you get? Okay. And I think that's a really compelling question. I think Anna is on the call with his Veneza study, but we're doing, building on Naval's work, we're doing this triplet, Veneza Magro versus CPX or FLAG-IDA in high-risk fit AML. And there, Gail, you can worry a bit less about whether you're randomizing to go to transplant or not, because you're starting up front. You're starting right at diagnosis and asking the central question of, does it matter what induction you get? And then patients who do go to transplant, and others don't, and just continue with chemo. So I think that may be one approach, but I think the danger is if we actually stop thinking about the interaction between induction chemo and transplant and what you do after transplant. It needs to be seen as a package.
Just to add to what Charlie's saying, I mean, I think for us at Anderson, that's kind of the big focus right now is, our transplanters are everybody's transplanters, right? There is a huge subjective component when you see that patient. And clearly when they're getting an HMA-VEN-based regimen, even a triplet with Magro FLT3, no mucositis, enterocolitis toxicity, we send them after 2 cycles, they're in remission, and we're seeing the transplanters are very eager to move ahead. Same thing, we give them intensive chemo with VEN or FLT3, that patient has infections, complications. So I think that what Charlie's saying totally is the first step. The bigger issue I have with these studies is how can you be adaptive? Because let's say you do an AZA-VEN FLT3 versus a intensive chemo FLT3, and you say we're going to take them to transplant. And my feeling is you will get more patients in a better shape to transplant with the triplet. But then what about maintenance, right? So do you do a second randomization, or do you do adoptive, or do you use molecular endpoints? And I think that may be the only way this can really happen, saying that, okay, we gave these 2 regimens, this many people achieved a molecular response before going to transplant. We now have a body of data showing molecular response is important to survival in FLT3. So we think that this randomization was either equal or 1-1. And then you take them to transplant, and then you have a second randomization where you say, now we're going to give a FLT3 inhibitor or not. Because when we all, see the morpho data, I mean, I've reviewed it, it's interesting. I mean, people are calling it negative, but that's not really at all what I saw when we see the data. So I think there are many questions. And what I worry is, can you lock in one randomization and then the field moves ahead in 3-4 years? And how do you adapt for that? And that's been our biggest concern, Anderson, is how do you move if you're locked in for 4 to 5 years? But I don't know, Charlie, Gail, what thoughts do you have for that?
Well, I want to throw one thing out there, and then also just being mindful of time, because Selina is going to chair the next session too, and we want to stay within time. But I really wonder whether one of the biggest barriers to knowing anything is how difficult it is to quote unquote define real world of what we're doing, because it's not my opinion that this can be done in a randomized way. I think that a randomized trial of this space is by definition not going to be, because you're pulling out IDHs, you're going to pull out the NPMs, you're going to pull out the FLT3s, you're going to pull out anyone who is too fabulous because you're going to want them to get, I don't know, more myeloablative. You're going to put out the not so fabulous. They're just, the randomization is going to be bogus. And I think it's going to be, I don't think it's going to actually lead to much more than a really good real world study. What I would love to do, and I think what Hert and Lars and some of the guys in Europe are doing better, we're trying. But if data use agreements and if data sharing can be a little bit less cumbersome between institutions and not require 50 lawyers and a year and a half for the contracts, if we actually really look at what we're actually doing, you can create a real world, quote unquote, randomization. This paper was an 8-year review by Sorora. This is an impressive piece of work that's difficult to pull together. We can do it better now, and it can be dynamic because you can use, as Naval said, the field is moving. By the time you get your randomized trial data, it's already irrelevant. I think real world has to be the way to go, because these trials are not going to happen. I mean that not to be a pessimistic statement, just a realistic one.
I would say that, not to drag the conversation on indefinitely, but to everybody's point, there's so much diversity in targets that we're going after and regimens that, standardizing that part of it would be difficult. But I do feel you can standardize and get useful information from the time of transplant if you can come up with a way to standardize the status of patients going into the transplant. And that could include, focusing on a group of greatest interest, those that are, for example, intermediate risk, that are MRD negative and that have a certain pre-transplant score that falls within a similar range. And, focus on that group of patients where the biggest question is. I don't think there's really that much of a question about, do we need a transplant? A RUNX1 or an ASXL1 patient. If we have the opportunity, we will. But I think if the question is getting to what we can focus on most importantly, I think there is an opportunity to standardize patients at the time of transplant, taking into account, recognizing there's going to be a huge diversity in what they receive to get there. But I don't think we've done a very good job at really addressing the standardization of patients at the time of transplant in a randomized fashion.
I would say here. If we characterize the patients correctly who are going into a transplant, it shouldn't be rocket science. There is no particular point or reason to assume that if you take really, really, really super frail patients and take them into a transplant, that is a group of patients that we're missing out on. That doesn't make any sense. We all know or think we know how to pick pretty good patients for a transplant. We should characterize them biologically, cytogenetically, molecularly, MRD, every single thing that we can do. And if a bunch of really good doctors analyze all of their really best for transplant patients and are showing that at 2 years, people aren't alive more than they would be with Aza-Ven or at anything else, I think that's important. And I think that trusting ourselves that if we can't take the patients who are best to go into transplant through successfully and give them a survival benefit and a quality of life benefit 2 to 3 years out, then it certainly doesn't make any sense that including other even more clinically marginal groups would be helpful. So I think we have to take another run at exactly what you said and just not try to randomize them, just characterize them. I think it's a great idea.
I think this has been a very rich discussion, and I think Jeffrey is right. I think one can define, perhaps with greater clarity and precision, a population who you would like to study. I worry a little, Gail, in some of what you say on the assumption that we think we know how to do a transplant. We think we know who will benefit from IDH1 inhibitors. And I think the quality of evidence, particularly around the transplant space, to support a lot of our practice is woeful. I could conclude by our experience in the UK, which is by having quite an inclusive protocol. This COSI protocol was quite inclusive, in which we are characterizing exactly the points that you and Jeffrey identify as important. We were amazed, Gail. We found that we were randomizing 20 patients a month. So I think there is an appetite to answer these questions, particularly among our generation. And I think it should be to try and look at this integrated proposition, very much echoing what you and Jeff have said. But my experience with FIGARO was that everybody in Europe said the sequential regimen was the way to go. All these centers were adopting it. I mean, we were. And they're in hospital for another week, and there's intensive chemo, and you run the study, and it is exactly the same. And we're causing a lot of toxicity, I think, potentially with some of our maneuvers. And were this to be a different clinical setting, the consequences, say, of giving lenalidomide inappropriately, we just, the whole world goes up if we are delivering drugs with unexpected or unquantified toxicity. And I think we do need to be more thoughtful about the toxicity of transplant and how we can assess it in prospective manner, either using real world data or rather more inclusive clinical trials, just as you said. So I think we're ending in violent agreement, Gail.
I think that I don't think we've quite cured AML yet, but we're trying hard.